Hello, everyone. Thank you for joining us for today's webinar session. For those of you who don't know me, my name is Shruti. I am one of the co-leads for the FY1 division of Mind the Bleep. So today our webinar is being presented by Izzy, who is a current FY1 but is also a psych lead, and she'll be giving you a talk on the essential tips for your psychiatry jobs, which we'll be embarking on soon. So Izzy, over to you.
So hi everyone. I'm Izzy, and thank you very much for that introduction. So I did my psychiatry placement first during my F1 training, which I think was quite a nice way to ease into F1, but definitely a unique rotation to start on, which perhaps wasn't representative of the other rotations I subsequently did. So I thought I would take you guys through what you can expect, the opportunities, and I think there are a lot of opportunities with the placement, which I think I wasn't aware of until I started it. And then a few helpful resources while you're on the rotation, and then kind of answering any questions at the end. And you can definitely put any questions in the chat as we go through. I think it will be a bit more of a talking session than too slide heavy, but I've got a bit of content just on there so that you can be kind of signposted for further reading. So I will go through the different settings that you might have a psychiatry placement. So I don't know if people are joining who are having it as F1s, but there might also be some of you that have a rotation in F2, and those can be slightly different. And then just the roles that you have within the team, and the tasks that you will carry out most commonly, and then the opportunities during the placement and any useful resources. So the general settings normally can be split into inpatient. So these are usually by age, but also by sex in terms of the wards. So you'll often, if you're placed on a ward, it will be a general male adult or general female adult. Older age can be sometimes mixed. So I was on a mixed older age ward, but usually they'll be split. And then if you're in a CAM service, so I'm not too familiar with CAM services, but I can imagine they're probably similarly structured, but it might depend on the location, and each trust is kind of different with how they split things up. Sometimes it also depends on what the conditions are that are being treated on that ward as well, in terms of how they're split up. So you can get specialist eating disorder units, specialist psychosis units, those kinds of things. So it might vary in that. And so it's good to ask early on what that is. And I think that the jobs can still be very similar, depending on what the subspecialty is in psychiatry, but you might just see more of a certain pathology than others, and other might be quite generalized, and you might see a good mixture. In a liaison setting, so you'll be in the general hospital and part of the psychiatry team. Sometimes this is split as general adult, so under 65s or under 80s, depending on the trust, and then the older age, who will see the overs. You might also do a bit of a mixture of both, but generally you'll be reviewing patients who are in for physical health needs, and sometimes there are social admissions that more fall under psychiatry. Your consultant will probably lead in terms of whether patients need to, have sectioning, or if there are initial reviews and treatment plans, but you might be kind of reviewing the patient through their journey and doing cognitive assessments or mental health assessments as they go through. So I think that will hold quite a bit of variety, and it would be very useful going forward in terms of other specialties as well, through that role. And then in the community, so there are different specialized services that split not only into the ages, but into different conditions. So I had colleagues who were on acute psychosis services, who would see people in acute crisis who were not unwell enough to be managed in hospital, or perhaps were being reviewed in the community for review as to whether they did need inpatient care. And those who were newly recovering from the first episode of psychosis, for example. I would say with community, it's quite an interesting job. You're going into people's homes, and those kinds of things. It can be a very humbling experience. It can be very eye-opening in terms of the different ways that people can live in the different communities in your area. So it can mirror slightly GP in that respect. But I think the colleagues that did those rotations really enjoyed the experience and found it very useful. So in terms of, I'm just going to focus on the kind of inpatient side of things. I think for the community, it would be slightly different, but some things might be slightly similar. So generally with the job role, it's kind of like any other F1 job. So there'll be a lot on kind of the ward round documentation, prescribing usually under supervision, especially in psychiatry, just based on drug choice and that kind of thing. It's not going to be you deciding. It's much more consultant driven downwards, or perhaps registrar if your consultant's not in. So it'll be that side of things. In terms of any new patient that comes on the ward, they are usually medically cleared. So even if they've come from hospital and transferred to a specialist psych unit, they'll be needing routine bloods on admission. In older age, they might do cognitive bloods. They might do bloods for drug monitoring, that kind of thing. They'll have an admission ECG and a general examination, and usually that's up to the juniors. You would be surprised what comes through the door that has been missed. So it's definitely something that is an important part of the job and will be good practice if you have this rotation first going into your kind of future medical and surgical specialties. You'll also be doing some of the mental health side of things. So it might be that you are doing cognitive assessments or certain assessments that are useful kind of quantitative markers of a patient's mental health presentation. So that might be the Beck's depression inventory, might be some of the anxiety scales, PTSD scales, those sorts of things. And they can be very interesting conversations. They can be good opportunities to practice your communication skills, especially. You can be talking about very intimate details of people's lives, their traumas, those kinds of things. It's definitely a very privileged conversation to have with people. And so it's definitely a very good opportunity to understand people's lived experiences, but also to gain those communication skills and that confidence for then any future conversations you have down the line, generally in medicine. As the F1, especially on call, you can be having conversations about ceiling of care, about prognosis, all of these things with and updating relatives down the line in kind of more serious circumstances in your future career. So in psychiatry, you witness so much communication in terms of the ward rounds and in terms of the assessments that you do. So it can be very useful to gain a bit of practice and see really the dynamic between the patient and the psychiatrist. And then generally you're working with the MDT, so it's kind of similar to most other wards in terms of you've got the medical side of things, you've got the nursing staff who in psychiatry settings do a lot of the work. They're the ones who are much more present on the ward, doing stuff with the patients. Then you've got psychologists as well. There's usually a ward pharmacist as well, occupational therapy, physiotherapy, and probably the only unique member of the team that probably you don't get so much in other specialties is someone called their care coordinator. So that's someone who acts in that they'll see them in the community on discharge. They might know them before admission, and they monitor their mental health and their social circumstances and their ongoing needs in the community. So they often give very useful backstory in terms of the patient's circumstances pre and post admission. And then, so for yourselves, usually in terms of the documentation, it's different to medical or surgical. So surgical is very, as many people can predict or will know, is very brief and details more an examination and those kinds of things. Whereas in psychiatry, it's usually ward round entries are written a bit more verbatim with a bit more detail to kind of really illustrate the dynamic between the patient and the team and the ongoing mental state of the patient. And so this is normally done with the mental state examination. So I'm not going to go too much into it. Mind the bleep, we've got resources about this. There's lots of resources out there, but I'll just touch upon how you might see this documented. And it will vary depending on what your consultant's style of choice is or your own, but generally you follow this formula. So you at first look at their appearance and their behavior, their speech, their mood and affect, their thoughts. So this is whether they have any delusions, if there's any paranoia, if there's any fixations on certain ideas. And then perception is if they seem like they're responding to any hallucinations, whether that's auditory or visual, or tactile, for example. And then do they have insight into their condition, insight into treatment, those sorts of things. And generally you might see when you're on the ward, when you're looking through ward rounds, it might be structured like this. It might be it's almost like a narrative. So this is like an example, and then I've got the kind of sections of the mental state examination highlighted in purple. This is obviously not a real case. It's just kind of created in terms of something that would probably be representative of someone with sort of nihilistic depression. So you might see that. Sometimes the wording changes. There's not a hard or fast rule in terms of how to do it. There might be resources out there that for certain trusts that are more clear about what they'd like, but generally this is something that you might see. And then just to touch on, so you'll see when you see people as inpatients, they'll either be an informal admission, so they have capacity to agree to admission and treatment, or they might be under the Mental Health Act. We've got our own articles about the Mental Health Act and the common sections, but if you would like quite an in-depth view of it, as the psychiatry page, we did a session with the Thinking Mind podcast, one of the co-hosts called Anya, who went through the common sections in a real case chronology. So that would be something definitely to watch before if you struggle to remember the different sections, because it can be a bit fiddly. But generally, if you're in an inpatient setting, you'll see much more of like section 2, section 3. If you're in the community, you might see people who are needing the police to take them, for example, to a safe place, to a hospital. And so that would be utilizing some of the different sections. So it can be very useful just to be aware of them. As an F1, you're of course not trained in completing any of the sections of the Mental Health Act, but it is worth knowing which ones they're on and what that entails, what the timelines are in terms of how long they will be under that section. Is it for treatment or is it for assessment? Those sorts of things. But generally your consultant will probably, will be very open to discussing those things with you. I would say with psychiatry settings, the unique things about them would be that it's definitely a different pace and a different depth to other specialties. So usually the pace is a lot slower, it's a bit more measured. The depth of the conversation is probably potentially more holistic. Depends perhaps on the setting, and it probably also depends on where the patient is in the course of their illness in terms of the conversation. For example, if someone is acutely unwell, might be briefer than when they are getting better and you're thinking about future planning and maintaining well-being, like post-discharge, for example. Generally, when you're in an inpatient setting, yourself and the other members of the team will sit in a room and the patient will be called in. So it's not like a ward round as such. That might differ depending on the structure of your ward and what your consultant wishes. So, for example, on my ward, which was older age, sometimes we would go and see the patient because they had limited mobility or some other physical health issue was going on at the same time, but that wasn't very typical of, for example, like the general adult wards that I saw. I would also say that And I think any good supervisor will discuss it with you, but to be aware of is the fact about personal safety and boundaries. These patients are often very vulnerable. You can experience people who are disinhibited, for example, that you may not have ever seen outside of this setting, or at least not for a prolonged period. And so it is worthwhile to think that just about your own boundaries with that patient. They can be there for a very long time. They can become, they can feel quite a strong bond with their team, and the fact that you've helped them get better. And so it is definitely worth being kind of vigilant of your own boundaries. And I think generally most people are, and it's something that your seniors will discuss with you, and it's definitely something you can always openly discuss, because sometimes patients test boundaries, but it's probably something that maybe crops up a bit more than it does in medical or surgical specialties, where patients are typically there for a shorter period of time. And then in terms of the sort of safety aspect, usually on wards there will be alarms that are available if you need them. Usually there is training for these sorts of things. It probably varies trust to trust, but just to make sure that you are asking for these things, and to also feel the need, feel that you can go to any situation with a patient, and if you're worried, that you can go with someone else, that you think about your surroundings, those kinds of things. And I think generally you think about this even when you start general medicine, like you're in A&E and you're meeting someone for the first time. It's always worth thinking you don't actually know what situation you're walking into. Me saying that is not me meaning to frighten you at all. I would say that the majority of us did not have any issues. It's just something better to be aware of than to kind of arrive and feel a bit out of your depth and feel like you can't discuss it with someone. Another good thing in psychiatry settings is often trusts will offer balance groups, which are these kind of reflective groups, or at least reflective time in your supervision. So if anything does crop up, or you have any of these concerns, you can raise them with your supervisor or the medical education team and discuss it with them. And I've generally found that there has always been someone who is receptive in every organisation. I was wondering, so just to touch, because I think it's quite important in psychiatry just to think about this, but does anyone know what diagnostic overshadowing means? And I'll just have a drink, just in case anyone wants to answer, otherwise I will go for it. Yeah, it's a Thursday, to be fair, so maybe people are just a bit quiet. But basically, diagnostic overshadowing is the attribution of someone's symptoms to a psychiatric problem when those symptoms are due to a comorbid condition, another condition. This can also be used for other things. So it could be that all their symptoms are put down to one diagnosis. So it might be that they have something like fibromyalgia and every symptom is put down to that, or they have a genetic disorder or something like that. But it happens quite frequently that a patient who has a psychiatric history, that their symptoms are put down to as a result of that condition, rather than thinking about other things. I think generally through better education and better training and all those things, that we've definitely gotten better as a profession at keeping an open mind. But it is just worth noting that as the junior on the ward doing the physical health checks and being a member of the team, you always can think about these things for your patient, in terms of that they might be being admitted, but they haven't been medically cleared, or actually they have ongoing medical needs that would require perhaps clinic follow-up or a second opinion, those kinds of things. We know that people with mental health conditions can often have worse outcomes in terms of physical health. That might be because the drugs they're on, that sort of thing. So it is worth just advocating for your patients in that respect. And you do often have a lot of time in this job, so you do have the time to refer them to outpatient clinics or to get second opinions, that kind of thing, tie them into community services for their physical health. So it's just something to bear in mind. And then other opportunities on the placement. So I would say that it probably depends on your team, but at least for mine, I was able to participate and lead in some ward rounds. So for patients who had been with us for a long time, I could go through my mental state examination. I could go through certain bits of their history with them, discuss their treatment with supervision on top of that, which was really, really useful. I was able to do cognitive assessments independently, and practice presenting patients and deciding on management plans. It was at least where I worked, it was a very flattened hierarchy in terms of every member of the team was involved in the decision making, and I feel like you don't get that so much in other specialties. It can be very top down, which can be effective for sure, but it is nice to have perhaps a bit more of a level-headed discussion, which I definitely found on psychiatry. You also get, as an F1, one self-development day a month. I spent mine, so I think what's good about psychiatry is often a lot of the different team members have been through different rotations. So the consultants have often done a community job, inpatient job, liaison job, and they know the people in your area that are in those. So they can help you out if you'd like to see another branch of psychiatry for the day. And I would say, even if you don't plan on going into psychiatry and you've got other specialties in mind, you can sometimes think, well, actually, it would be quite nice to see, if I'm on inpatient, it might be good to see what the community teams do and understand the scope of their work. So I did a community day, which was with the general adult team, which involved lots of home visits, which was very interesting. I also spent a morning seeing electroconvulsive therapy as well, which I think was a really valuable experience to kind of demystify a therapy that's often kind of dramatized in films, dramatized in the media, which actually you can see the real life benefit by seeing your patients have it and see the positive results afterwards. I would say also, in terms of psychiatry placements, you often have a lot more time than you do on medical and surgical ones. So it is worth being a bit organised about your portfolio, which, to be honest, I think is often quite anxiety provoking, but is sometimes actually less sign-offs than medical school was. Sign-offs are easier to get than medical school. And you can, if you're kind of consistent, you can get through it. I think most of my colleagues who had difficulties, it was because they were coming towards the latter point of the year in a bit more of a tricky specialty to get sign-offs. So it is worth just doing those things. I often as well utilize the extra teaching opportunities. My consultant was very pro going to these extra teaching sessions, and obviously those count towards the portfolio points as well. And for example, at my trust, there was a monthly teaching afternoon which covered things like global psychiatry, where you learned from people in other countries about their psychiatry services, clinical trials, those kinds of things. So it's up to you what you make of it as a specialty, but there is definitely different opportunities within it. And also, generally, there's a more flexible rota. I was on 9 to 5, which meant I didn't have that much money, but I had a lot of free time. Probably my mental well-being was probably the best in psychiatry as well. And the leave was very flexible, at least for mine. It may not be, globally that way, but I think compared to the other specialties, often it can be. So as well, just thinking about how you utilize that for yourself. So I pushed mine. I kind of took a week off nearer the end before I knew I was starting a much busier surgical block as well. So, but it's up to your individual preferences. And then in terms of useful resources, so the Morsey guidelines are very good for drug prescribing and the the treatment plans for different conditions. I obviously would be a pretty bad psych lead if I didn't talk about the psychiatry page, which we're slowly adding to. There's quite a lot of the bread and butter stuff there as well, and then a few more articles that are a bit more specialist. So I've added a few in terms of the old age psychiatry scope of the job. So prescribing in that population, conditions in that population, and then a few more on the other therapies as well. And we'll keep adding to it. The new psychiatry co-lead, so I'm getting a co-lead, which is very exciting. The new co-lead will focus a bit more on the CAMS and paediatric presentations, which will also overlap with specialties like GP and A&E. So I think that will be slowly in the works. So keep an eye out for those. And then I've also mentioned the BMJ learning, they've got some very good modules across all of medicine and surgery, I have to admit. And I would do these, on when I had a few hours free here and there, because they count towards your teaching hours, but also were quite good in terms of giving interactive scenarios in psychiatry and in medicine as I went through. There's also the Royal College of Psychiatrists e-learning hub, which I think has also some very good resources. And the Royal College of Psychiatrists, if anyone is interested in the specialty, has very reasonably priced conference tickets for different things throughout the year. So it'd be worth just having a look at those, because the F1 rates are definitely much more reasonable compared to the other colleges. And if you're interested in presenting things like quality improvement projects, posters, I think most of the psychiatry focused conferences are very, very pro and very, just very pro juniors, I think. So it is worth just seeing what's out there. There's a few kind of essay prizes and other things, for sure. And then just to kind of circle back to the Mind the Bleep side of things, we've recently finished our psychiatry series. So we covered psychotropic medications, the Mental Health Act, leadership and team dynamics, and a couple of other topics. So it might just be worth just having a look at those if you'd like to explore kind of, and there was also communication skills. If you would like to cover some of the stuff to do with kind of core psychiatry principles, general kind of useful tips about the kind of real life medicine, about teams that don't work, about difficult patient interactions. They've really delved into some very interesting stuff in terms of the personality theory behind certain interactions, about other things. The Thinking Mind podcast very helpfully offered to lead those sessions. And if you're interested in other resources, so I just kind of listed what I listened to and read while I was on the rotation. And some of these I kind of finished after the rotation. So by all means, you can just chill out. And I just seem to have quite a reasonable amount of free time. But in terms of books, I read It's All in Your Head by Suzanne O'Sullivan. So this is about psychosomatic disorders and the myths and the truths of these conditions. And I think these conditions you see throughout medicine. You'll see them on your surgical placements, in general practice, in psychiatry. And it's a very interesting book to create sort of a wider scope of knowledge about these conditions and kind of demystify a lot of the stigma around these disorders. Cracked was an interesting book about it. Kind of the title is much more negative, perhaps, but it's more talking about the potential over-medicalization of certain psychiatric disorders and the controversies about over-diagnosis of certain psychiatric disorders, such as things like ADHD mostly and anxiety, and about medicine prescribing in the United States particularly, and the issues that they've had around that, which has been very interesting. would recommend. And then Empire of Pain also fits slightly into that. So it's about the Sackler family and the prescription of like OxyContin, which is a powerful painkiller, which was it's been used a lot by patients in the US for chronic pain syndromes and that sorts of thing. But the three brothers that founded that company and were the start of that family, all went into psychiatry. And there's a lot in there about how they shaped psychiatric research and especially the drug market. So I would say that I've just put my examples of what I chose to read, but there's obviously a huge heap of psychiatry content out there. There are different books. So if you're much more into psychodynamics and the theory and all of those things, there are lots of books out there that are very interesting. If you're more interested in like the global health side of things, look at that. But I think it's definitely nice, especially finishing medical school, where picking up anything that wasn't a textbook was pain. It's actually very nice to get back into reading. So it's not for everyone, but I would recommend, actually when you don't have to revise anymore, just giving like reading a bit more of a reset, I think. Because I, for one, definitely lost my mojo in terms of reading books during medical school. In terms of podcasts, so the Thinking Mind podcast helped us greatly with our series, and they've got a lot of interesting content. They've interviewed lots of interesting people, including Suzanne O'Sullivan, that read the first book on that list. And they've got some shorter audio essay episodes as well. And they explore different areas of psychiatry. There's a mix of things like shared lived experience as well that can be interesting that you can listen to on the commute. And there's also Braincast, which is another Maudsley learning podcast, which is with a very charismatic host. Actually, I think it's just finished, but he interviewed a lot of different people in psychiatry. It included things like functional disorders and schizophrenia, those kinds of things. So again, just like a slightly different variant. And I think that podcasts are quite a personal thing. Some people, everyone picks what they prefer. Some people prefer a kind of calming demeanor. There's all different things. So I just thought I'd put up a few. And then the Lancet Psychiatry, they also interview people in the field worldwide. And then the other one, which I found, I kind of came across a bit by surprise, but the Forensic Psychology podcast is very interesting. It's hosted by two women who are psychologists in the prison system. They talk about the difficulties in terms of doing psychology in the prison system, the stats. So they've got some really interesting stuff, because I think also as medical students, a lot of us did not get any forensic placements, and so it can be quite interesting to see their point of view from their experience working in it. So I thought I'd throw that one in as well. I think that is like coming to the end of my ramble. But I generally just say go into your psychiatry rotation with an open mind. I think you can get these ideas of what it will be like based on a few days from medical school, but actually doing the job can be very different. I think it's definitely a job where it is what you make of it. You have a bit more time. You can think about what other things can I be doing. That also might just be chilling out and having a lot of time to reset or to explore your other interests, like when you're doing your potentially 9 to 5 regular Monday to Friday job in comparison to a on-call medical rota. I would say that the skills that you learn in the rotation are definitely transferable. You learn a lot about communication, about patient to doctor dynamics, about family dynamics. So it's definitely something that crops up. And I think in whatever rotation you go on to next, you'll be able to identify people that you think would benefit from a review by psychiatry of a focus on their mental health needs as well as their physical health needs. I think also it's one of the most supportive rotations. I think most trainees find it very supportive. I think that that's also because the consultants that you'll work for have probably a bit more time. I think that's a fair thing to say. So you should be kind of advocating for your 1 hour a week of supervision, and you can use that how you want. You can discuss cases that you've seen, or you can discuss different areas of psychiatry. You can definitely use them and their knowledge in terms of how to manage patients, about other teaching or learning opportunities, about using your self-development time. I would say it's definitely like a rotation that you can use for personal growth. I definitely really enjoy. I was very surprised by my psychiatry placement. I think going into it, I wanted to hit the ground running with some medicine, and actually I think it gave me the grounding I needed to then go into those other specialties for sure. Okay, I hope that's been useful, and I will, if you have any questions, just hit me with them and I'll try my best to answer them. I think if they're trust specific, that will be a bit tricky, but just if there's anything that you'd like to ask about your upcoming psychiatry rotations, about anything that I've said in this presentation, just go for it, and I will answer it as best I can. So I would say that, so someone has asked what the dress code is for psychiatry. I think it's dependent on where you are, if you're in community or in liaison or in inpatient. I would say generally just smart clothes across all three would be fine. I think in inpatient, you're more than welcome, and you lots of people that wore scrubs, but it's definitely something just to ask when you go for your trust induction. And it might be that there's a limited supply of scrubs. That sometimes happens. I would just think about, in terms of what you wear, they'll give you a lanyard that has the kind of safety break points in it, but just have a think about what you wear in terms of just like, some of us might wear like the odd necklace to work normally, but just about jewelry, those kinds of things, earrings, just in case they get pulled or any. I mean, it would not happen very often, but I think what I felt was that I didn't want there to be an opportunity where I was going to find out. But I don't think it's very common. But yeah, by all means, you can be smart. You don't have to also buy like a tweed jacket or whatever the stereotype is. Mostly they just, everyone's just wearing the usual stuff. Does anyone else have any questions? I do feel like psychiatry, I think the title is survival, right? But I think it's probably one of the lesser daunting specialties.
Hey, sorry. Thank you so much for that. It was really nicely presented. I really enjoyed it. It was just reminding me of my own times during psych as F2. But yeah, definitely agreed. Going with an open mind is really important. You see a variety of patients from a variety of different backgrounds, and I think for me, it definitely made me feel like more grounded and a bit more humble from with our backgrounds and stuff. So yeah. Oh, we've got one more question. Are we expected to prescribe treatments?
You are. I would say that it's almost less daunting than in medicine or surgery, because often you've got that bit of discussion. Like your consultant will say, I think, for example, aripiprazole is the best for, this condition, and we should go for this dose, and you're kind of prescribing it, but it's very much senior led. So I think I wouldn't be worried about it. They're not going to say up titrate the sertraline and vanish. It will be very clear, and you'll have your ward pharmacist as well. So if there's any kind of queries, you can ask them. And there's a lot of guidelines out there as well, but usually your consultant will just tell you, so it's not too much of a worry. And then in terms of, so was it a big jump when going to the next specialty? I mean, I did psychiatry and then general surgery and started on call. So it was a big jump in terms of going from a ward round of sitting and the patient coming to you to like 50 abscesses or whatever. But I would say what I would do is that often you'll have your kind of afternoon teaching at the main hospital. And so I would probably just go for a few hours. I think for me, it was more the computer system, is that I learned it on day one and then went away for 4 months to do another computer system and then came back. And I think it will be a jump, but I think it will be fine because also, even if you do it first, all your other colleagues will have already done a rotation. So the other F1s will be able to help you. It's not, you're kind of missing that busy bit. And then in terms of if you're going from one computer system to the psychiatry one, often the psychiatry ones are a bit simpler and it's not so time pressured. So you've got more than enough time to get your head around it, and you'll have an induction for that as well. So I hope that answers the question.
And then is the next one, is there anything that we would need to prepare study-wise before going into psychiatry?
I would just say, I mean, you could go in and everything be rusty, and that's fine because you will be able to build on that. I would just say, I think just being able to do the mental state examination for sure would be probably the best place to start. And then a lot of the time you can look up resources to familiarize yourself, and you'll see lots of different patients with different conditions. So the knowledge will kind of build from there. So I wouldn't worry. I wouldn't say that you have to, know all of the major criteria for certain conditions, nothing like that. I think your team will kind of lead that for you. Yeah.
Yeah, definitely agreed. MSCs were something that we had to do quite often, but also just revise how to put an ECG leads on, because you might be asked to do that quite a bit for any clackings and stuff. And going through ECGs as well. Maybe have a look at it prior, like especially looking at the QT interval and how to calculate that, because some antipsychotics can increase your QT intervals and stuff like that. So that's something to bear in mind. But besides that, yeah, as you said, like you can go in and build up your knowledge through your rotation. Any other questions? I'd also like to send a feedback form if everyone can spare a few minutes, literally 2 to 3 minutes of your time to complete the feedback form. That'll be very useful for us in terms of creating other webinar sessions, and for Izzy as well, for feedback for her teaching as well. Any other last comments? I guess not.
Yeah, no worries, guys.
Thank you.
Thanks for coming.
Yeah, thank you, Izzy. Thank you for your time. And if you want more psych-related lectures and stuff, the psych team within the Mind the Bleep are hosting events. So do keep an eye, and do keep an eye on their previous videos as well. Are they uploaded on Medal and stuff?
Yeah, they are. And also just generally, if you ever want to get involved in any psychiatry articles, especially when you're on your psychiatry placement, we're always open to them. So feel free to write one with your consultant about a topic that interests you, and send it through to us through the email. We can have a look at it. And also, if you want any specific content that you find along the way with your placement, or you think would be a really good idea, just let us know. We're always looking for inspiration. So, yeah.
Brilliant. Thank you so much, guys. Thank you. And also thank you, Izzy, for your time.
Yeah, thank you so much for organising. Cheers. Have a good evening. Bye.
You too.